Welcome, everyone. We'll wait just a minute or two to get time for everyone to sign in. Feel free to introduce yourself via the chat, and we'll just wait another minute or two to give everyone time to get signed in. Okay, feel free to introduce yourself in the chat and note that you do have two different options. So you'll want to select chat to everyone when you're introducing yourself. There's also an option to chat with hosts and panelists. And we'll give it one more minute to give time for introductions, and then we'll get started. Okay, good afternoon. I'm Karen Schetzina. I am director of the ETSU Child and Family Health Institute. Welcome to this month's collaborative series. You probably noticed the message when you signed in that this session is being recorded. The recording will later be posted on the ETSU Child and Family Health website. As I mentioned, you can chat to everyone, an introduction, and it's great to see so many, I won't say familiar faces because unfortunately I can't see your faces in this webinar format, but I'm glad to see people from across campus. We've got students and a number of people from the region and the community. So welcome to everyone. So I'm going to serve as moderator for today's session. This session is scheduled to go until 1:30 since it's a panel discussion that's a half hour longer than our usual collaborative sessions. And we've prepared a series of questions that we've collected that I'm going to pose to our panelists. We do welcome your participation by sharing any questions that you have about COVID-19 and children via the Q&A. So you can also put it in the chat, but I would recommend the Q&A. If you go to your controls at the bottom of the screen, the Q&A button should be kind of to the left of the chat, and that'll just help us better be able to keep track of which questions we've already answered. So feel free to answer questions at any time. Katie Duvall is our coordinator in the Institute, and she is going to be monitoring the chat, and we'll have several breaks throughout the discussion where she can share those questions. Everyone is muted right now and will be muted except for the panelists. However, you can raise your hand. So when we have those Q&A moments, again, look at the controls all the way on the right-hand side. There's a raise hand. And if you do that, Katie can unmute so you can ask your question. So that's how things should work today. So today I am thrilled to have 3 expert colleagues here for a town hall style panel discussion on COVID-19 and children. I'm now going to briefly introduce each presenter, and I will invite them to share any opening comments about their participation in this event today. So first off, Dr. Will Dalton is assistant professor in the ETSU Department of Pediatrics. He is board certified in both medicine and pediatrics and provides care in our adolescent medicine clinic at ETSU Health, as well as in general pediatrics. He also serves as medical director for the Washington County Department of Education. Welcome, Dr. Dodd.
Thank you, Dr. Skatsina. It's a pleasure to join today, and I look forward to our conversation.
Thank you for being here. Dr. Gayatri Jaishankar is professor in the ETSU Department of Pediatrics and medical director of the ETSU Health Pediatric Clinic. She is a fellow at large for the East Region for the Tennessee chapter of the American Academy of Pediatrics and has been active in state advocacy and education on COVID-19 in children. So welcome, Dr. Jaishankar.
Thank you, Karen. It is my pleasure to be here, and I look forward to our discussion in being able to communicate with all of you.
Finally, we have Dr. Jody Palaha. She is professor in the ETSU Department of Family Medicine and director of the Institute for Integrated Behavioral Health. She recently was awarded a HRSA grant for 5 years to train and place behavioral health consultants in the primary care clinics throughout ETSU Health and in our community in an effort to improve access to mental health services. She is also a Washington County Commissioner. Welcome, Dr. Palaha.
My alter ego, Jody Jones. Props to you, Dr. Karen Skatsina. You always do the right thing in bringing the community together and getting important messages about children and their families' health out to the community in a way that is engaging and fun. And I am so glad to know you and be here today.
Well, those are very kind words, Dr. Jody Jones Palaha. Thank you for being here. So wonderful. Let's get started. And what we can do now is, we'll stop screen share, and Dr. Dodd has some slides that he's going to share. We have seen COVID-19 infecting, making children ill more frequently in recent months, as you all probably know, with some children becoming seriously ill and being hospitalized, both in our community and in our nation. To date, over 6.2 million children in the United States have had a confirmed COVID-19 infection. Children represent 16.5% of all COVID-19 cases. Fortunately, at this time, severe illness in children, while it occurs, is much less common than in adults. National data suggests that children 0 to 18 years of age represent 2.6% of all hospitalizations for COVID-19 in the United States. Dr. Jaishankar, let's start with you. What can you tell us about what COVID-19 looks like in Tennessee? Okay, you're on mute. We always have to say that once in a webinar, right? That's number one.
Yes, I'm on mute. Thank you, Dr. Dodd, for sharing the slides for us today. I would start by saying, unfortunately, and it's never nice to be on like top of the charts for something like this, but unfortunately, we are not in a great position in terms of COVID-19 in the state of Tennessee. The burden of disease is pretty large. This is from our Tennessee Department of Health website and is updated about every week. These are the critical indicators that you can see as of October the 20th. And you can see a huge number of total cases, 7.4 to 8.9% positive rate, kind of currently an unfortunate number of deaths, 51. And then one thing to note, though, is that these numbers are in fact a lot better than have been in the last few weeks. If you go to the next slide, that's again Tennessee in a glance, kind of through the pandemic. So Tennessee has been one of the states that has been affected by a significant burden of disease with COVID. And then I did this just to look at kind of our CDC website to look and see where we are in terms of transmission. If you look at the graph in the corner, yes, the number of cases are thankfully coming down all across the US. I'm always excited to see like rising numbers of vaccines administered, but very sobering to see the total number of deaths, the total number of cases. And of note here, like when you do a county check for Washington County, we are still at a substantial transmission rate in Washington County with sort of these guidelines in place that you read ahead of you. I think this is just a nice graphic kind of showing us from the Tennessee Hospital Data Association, the new cases by age group over time. I believe Dr. Dodd was also going to help share with us some other data about specifically the older age groups of kids.
Yeah, so I included this slide to really highlight the fact that the teenage age group in the Delta surge was very severely affected, and this is a very common illness in this age group. I believe we're going to touch on some of the symptoms in this age group as the next part of our discussion.
That would be great. Yeah. So that was a fantastic review of some of the population health data. Could you tell us more about how COVID-19 is presenting and how it's affecting children physically? What is that looking like, particularly in the kids 12 to 17 that you serve, Dr. Dodd?
Absolutely. Again, as this graph shows, that's been a very severely affected age group with the Delta variant or the Delta surge. So we've seen a lot of COVID in the clinic. Typically in teenagers, it presents very similarly to adults. So it runs from asymptomatic disease to shortness of breath, dyspnea requiring hospitalization for respiratory issues. Typically, the most common presentation I've seen in clinic is a flu-like illness with very severe body aches and sore throat. Any patient like that with those symptoms would be at high risk for COVID. And we screen everybody with respiratory symptoms, more or less, but particularly those patients, you have a high index of suspicion. Another presentation that I've very commonly seen is sinusitis type symptoms. Patients often dismiss this as seasonal changes, but clearly we're in a high risk time, and I always encourage them to get tested.
And I would add there, Dr. Skatsina, that COVID is mild in children. So, data shows that 40 to 50% of the time you are asymptomatic. So that is sometimes one of the pieces with COVID in children is nobody suspects that they may have COVID. We see that little kind of smaller population, when they come to us, they're already sick and they're trying to say, I'm sick and I want to be looked at a little bit more or figure out what's going on with me. And so all of the presentation that Dr. Dodd described is very true of the people coming into our clinic who may have COVID. But there's probably a bigger swath of people out there who are very mild and if not asymptomatic, whom we may not even see in our clinic. That can be one of the typical presentations for children.
Certainly. Well, and we are getting now further and further into typical cold and flu season. Could you talk a little bit more, Dr. Jaishankar, about symptoms in the young kids under 11 or even infants? As pediatricians and probably as parents too, we always think about the fact that young kids will often get sick half a dozen times a year, if they're healthy, typically developing kids, from some sort of maybe febrile illness, sickness with a fever. It makes it challenging, I think, when you've got to also think about COVID-19 in that context. So any comments about symptoms in the younger kids?
Yes, and like I said, often they can be asymptomatic. Sometimes they present a simple common cold. They can very much present like any other virus. So when they come in with a fever and cold symptoms, is this the flu virus, which we've seen so much less of after, as a lovely side effect of masking, I would think. But, is it the flu virus? Is it some other garden variety virus? Is it the COVID virus? Is sort of hard to know. Again, as part of some of these strange things that are happening with COVID, we've seen such a surge of RSV virus at a time when we usually don't see it. So is it the RSV virus with the cold symptoms and the fever? But typically, we've had lots of guidance from the Tennessee Department of Health also. Almost really any symptom could be a symptom of COVID, which sometimes makes it hard. So you can have GI symptoms with COVID. You can have, I think the one thing in our brains as pediatricians, we think if they truly have just urinary symptoms and very typically a UTI, then that's probably least likely to be COVID. But really anything else, runny nose, cold, earache, sore throat, fever, cough, congestion, vomiting, diarrhea, you name it, it could be COVID. And so that, I think, is what makes it hard sometimes when these kids come in there, to have to be able to, one, sort it out, and two, like Dr. Dodd mentioned, to have to universally sometimes test them to be able to know, what are we dealing with this time?
That makes a lot of sense. Now I know that, of course, some kids have more serious symptoms. Could you talk a little bit about long COVID and MASC, some of those more serious complications of COVID-19 in children?
Sure. So anecdotally, I've seen many adolescent patients who are complaining of persistent symptoms after COVID infection, whether it's respiratory issues, more fatigue or sleep problems, more trouble concentrating, or psychiatric issues. Some patients complain of anxiety. Some patients complain of trouble smelling and tasting that persists after the COVID infection. On a national or bigger research level, the jury's still out on the true impact of long COVID symptoms in the pediatric population. This is a recent review article that came out, I believe it was in the Pediatric Infectious Disease Journal, discussing several of these recent studies on long COVID in the pediatric population. very few of them had controls, so were compared to other febrile illnesses. As you can see with the bar graph on the right side, the prevalence of long COVID symptoms is all over the place. I believe the adult literature really supports some persistence of some persistent symptoms after COVID infection, but as far as the pediatric population goes, the data is still coming together. And the other complication that we see largely in the pediatric population is an entity called MISC or Misc, and I believe Dr. J was going to touch on that.
Sure. And so this multi-system inflammatory syndrome in children is known to be a delayed immunological response, known to be related to COVID-19. In the past, as pediatricians, we had a similar type of illness in Kawasaki disease. So for those of you that may have known of Kawasaki disease in the past, sort of had a similar presentation. But basically, these kids present after COVID with an ongoing fever, GI symptoms, a skin rash, inflammation in their eyes, which is sort of red eyes, not really conjunctivitis, but more red eyes, and then weakness. If you go to the next slide, Dr. Dodd, that's the CDC case definition for MISC in children. And so you have to be a child, less than 21 years old. You have to have a pretty significant fever, over 38 degrees for over a day. And then we can check some labs to check for evidence of inflammation. And you usually, by definition, have to have a severe enough illness to be hospitalized with it. And more than one of your organ systems are involved. So not just that your heart is involved, but your heart may be involved, your lungs may be involved, your kidneys may be involved. And that's sort of manifested by the red eyes, the skin involvement, the stomach problems. And of course, with all of this, you have to have either had COVID positive documentation prior to or right after or during that illness. This is just a nice graphic I found in circulation that kind of goes over the same thing.
So, we've learned a lot about the COVID-19 virus. As you mentioned, Dr. Dodd, there's still more that we're learning, and I think particularly about impact in children. But one thing that we know is that the virus can change, right? It can mutate and new variants can emerge. And one of the main reasons why we've seen an increase in rates in recent months and in children is because of the Delta variant of COVID-19. So Dr. J or Dr. Dodd, what could you tell us about what is known about how presentation illness might be different with the Delta variant?
I can go first. So the Delta variant is known to be much more infectious. And I think that's really the big piece with it. And so you can see this is another critical indicator off of the Tennessee Department of Health website. In September, October of this year, the sort of surge that happened, and that was really pretty much attributed to the Delta variant moving in. If you go to the next slide, that is specific to our East Tennessee region, and you can see that we were one of the higher spiked regions. So, following Mid-Cumberland area, East Tennessee in the red here was where some of this huge spike of cases existed. And it really has been, like in other parts of the country, attributed to this high infectivity or a highly transmissible Delta variant that we did see. And then this is just a breakdown by age group of cases of COVID that we saw. And again, you can see sort of this spike in COVID cases in that time frame.
Thank you for that, Dr. J. So one more question for you, Dr. Dodd. You all have highlighted already a number of differences between COVID-19 in kids versus adults. And I know you are board certified to take care of adults as well as children. What else can you tell us about how kids' experience with COVID-19 has been different than with adults?
So I think it's a really interesting situation because there's a lot of anxiety associated with COVID. Understandably, it's a terrible pandemic. It's resulted in 16,000 deaths in our state, and these children are going to school, which, as we see by this graph, is a very high risk place for exposure to COVID. Typically, patients whom I've diagnosed with COVID are very anxious about prognosis. They're very upset about the exposure, and they have a lot of questions about the future that I really have difficulty answering based on the data that we have. I think it's interesting, particularly for the teenage population in some ways, because they do have significantly lower risk of hospitalization or death than even somebody in their 20s. So from a medical standpoint, in terms of direct effects of COVID, the respiratory effects, they are lower risk, but there's still so many concerns that patients and their families have.
Well, and then you talked about, particularly with the Delta variant, how much more contagious it is. And so certainly anytime a child or teen is infected with COVID, then you've got to think about impact and potential for infection in the adults, maybe adults with chronic conditions or higher risks in that household.
Yeah, no, I've seen many families with children who are raised by grandparents who end up not doing well with the infection, and it's just a tragedy for so many families.
Well, Dr. Palaha, I finally have a question for you with all of that discussion about physical effects of COVID. Let's talk about mental health effects. What can you tell us about effects that have been described in terms of COVID-19 infection in kids?
Sure. And, the tough thing is the first sort of wave of COVID affected adults, as we've just been discussing, so much more. And we had very little data from that first wave that we've finally now started to really look at on children. We really only got a good sample of children with the Delta variant coming through. So our knowledge about how the Delta variant, COVID in particular, having COVID, not the pandemic broadly, because we'll get to that next, but actually being sick with COVID and how that affects children's mental health is just something we just went through it in the last few months and don't have any research papers or summary papers, but we just have our own anecdotal sort of stories to tell. But there's no known connection between having the illness and a specific mental health issue. With adults, there were some documented I don't know if they were studies per se, but there was some data suggesting that there was a higher rate of depression in folks who were diagnosed with COVID-19, and I just don't know how that will translate to children who are sick with the virus. I will say anecdotally that, and and sort of as Dr. Dodd was mentioning earlier, there is a higher level of anxiety and concern surrounding illness, this particular illness. And kids play off, they take their, the play from their parents. So to the extent that, parents are extremely anxious and, really make dramatic changes to the family's lifestyle around the illness, maybe in part because they have to take care of their child, and there could be other factors. Really the child takes the cues from that. So for all of you out there that are parents, and this is always the recommendation, right? To play it as normal as possible and as matter of fact as possible, to keep the questions for the doctor separate, maybe even, so that you don't add another level to a very challenging illness to begin with is the recommendation. Should I talk about the pandemic more broadly?
Yeah, you alluded to that.
I guess your next question.
Yeah, infection is one thing, but we've all, our kids included, have been experiencing a pandemic. So yeah,
Right.
could you talk about that in terms of mental health?
Right. And this is where we really have a little more to say, because, we have many examples of historical adversity that have threatened societies, natural and human-made disasters and recessions and other kinds of things that give us a sense of how these kinds of crises affect the well-being of families and children. And so, from the beginning of COVID, we've been able to look at how this one is like others. And similarly, we note that these kinds of imminent threats to relationships, to consistency in the environment and rituals, routines, all of the things that have been disrupted due to COVID can have major implications on children's coping and mental health during this time. And you've heard the expression before about how we're all in the same storm, but we're in different boats, maybe is how you've heard it. Our experiences are not the same. It's COVID for everyone, but some people are going to be more impacted than others due to their prior circumstances, like those with lower income, perhaps folks who lost jobs due to COVID, families who already struggled with mental health or other special needs, and folks who experience racism or marginalization. I think in our region, health disparities should also be taken into consideration, and families who came into this crisis with existing disadvantages due to those kinds of inequities. So, those all have to be taken into consideration as we think about this. Now, the pandemic of 2020 had a much more noticeable and measurable sort of impact in that we were all lights off in the house, batten down the hatches and wearing the masks and watching the news and doing a lot of things to protect ourselves and shelter. We're in a new phase. And I think what we're experiencing now is all of the sort of reverberations and costs associated with the time frame during which we were all pulled back. Because now everybody's expected to go back to work and go back to school, and friendships that were formed before have changed. Maybe, at least in my family, sports kids played before the pandemic, they don't play anymore. So now social circles have shifted. Some of the academic costs of learning remotely are being felt in the next year of school, when those things were expected to have been learned in order to build upon them for the next level of math or the next level of reading. And so we're starting to pay those costs. And again, this comes back to some families paying a bigger price than others, depending upon how they came into all of this. So I think that is, the big picture. I really wanted to just make sure I mentioned that, I feel like this phase of the pandemic is particularly challenging. And I think people don't, during the crisis, I think we all knew we were in this crisis and kind of gave ourselves more of a pass, perhaps. But now it's expected that we're back to life. And it doesn't feel like we have any, excuses for some of the challenges that we're having to work through after the difficult year we had last year. In many ways, this year may feel much more difficult for some people.
Yeah, you've heard the term just pandemic fatigue. It's just wearing on a lot of people right now. Parents,
and I'm starting to see, and I'm sorry to interrupt you, but I wanted to also mention I'm starting to see more writing on parenting burnout and parent burnout, which didn't come up as much during the pandemic when we during the first part when we were all sort of pulling ourselves from within to kind of get through, and then now we are tired, right? Frankly.
So a little bit later in this session, we are going to talk about ways that we can help overcome that, right? And be resilient. But first, let's go ahead and open things up for some questions from our attendees. If you've not already, feel free to put a question in the Q&A. That helps us keep track of which ones have been answered. And Katie, why don't you go ahead and share any you've seen that are related in particular to what we've talked about, symptoms and kind of effects of COVID-19 in kids.
All right, so Kelly Moore has asked, have children reported more often loss of taste and smell as a symptom? And I think Dr. J, you were interested in answering that question.
Sure. So it is a great question in regards to children. It kind of, I think, depends on the age of the child. Of course, the older children are more able to express, yes, I can't really taste, I can't smell. But it is not something typically that we have children coming in and saying, I really can't taste or smell. The adolescents probably, yes. What we do see, though, in the younger kids is that parents report they're not eating very well. They haven't been eating well in the last few days, or, and we kind of take that as a reflection of maybe the loss of taste or smell in that younger age group. Dr. Dodd may have an adolescent perspective on that too.
I'm not sure if the any studies showing a percentage of patients, but I can say I've seen several adolescent patients, typically those with the body aches, fever type of, maybe a little bit more severe illness, complain of either foods tasting different, typically soft drinks would taste different, or inability to smell. So it is relatively common in my experience.
That was a great question. I don't see any other questions right now in the Q&A. Did anybody receive any others? And don't forget, if you're an attendee, you are muted, just since this is a webinar, but you are able to raise your hand. And then Katie can unmute you if you'd like to ask a question.
Okay, so we just had two more questions come in. Don Dale asked, what is the best scenario projection for 5 to 11 vaccinations in this area, and what degree of parental cooperation do you expect? But we may want to hold off on that since we're moving into vaccines. What do you think, Dr. Skatsina?
Sure. Yeah, and I saw Hannah Winston asked, do you find that parents who may be reluctant to get vaccinated themselves are more willing to consider it after their children contract COVID? So yeah, let's go ahead and move into our vaccine portion of our discussion and get to those great questions. So in May, the Pfizer COVID-19 vaccine was approved for use in children 12 to 17 years of age as the 2-dose series. To date, 13.6 million children in the United States have received at least one dose of vaccine. Among all 12 to 17-year-olds in the US, 58% have received one dose and 49% are fully vaccinated. These rates do vary significantly by state and region, however. In Tennessee, only 38% of eligible children ages 12 to 17 years have received at least one dose of the vaccine. So I'll turn it over to our panelists and wondered what your thoughts are in vaccination. Why do you recommend COVID-19 vaccination? What are the benefits?
Sure. So do you mind if I take a stab at this first? So when I'm approaching an adolescent patient and having the vaccine discussion, and I do make a point to have this discussion with more or less every patient, I think it's an important discussion to have, both for the health of our community and also the health of my patients. I approach this from three different standpoints. So first, the vaccine is very beneficial to the patient themselves. As you can see on this slide, vaccines are very efficacious at keeping people out of the hospital, reducing severity of disease. They're also efficacious at reducing transmission of the disease, which is my second point of emphasis for these patients. A lot of patients are motivated to become vaccinated to protect their families. Like Dr. Skatsina had brought up earlier, a lot of patients are raised by grandparents or live in extended family households and have relatives who are high risk living in the household. And this is a way that those patients can take a step to help protect their family and reduce transmission. And finally, and this goes along the reduction of transmission line, there is a benefit to the community of taking a vaccine and reducing that transmission, reducing burden on the healthcare system. And in some ways, it's a civic duty to become vaccinated and help us all get through this pandemic.
So we've got data on the effectiveness of the COVID-19 vaccine. So, we know that there was an exciting announcement earlier this week that the advisory board to the FDA unanimously recommended approving the Pfizer vaccine for use in kids 5 to 11 years of age. It's next going to have to be approved by the FDA, recommended by the CDC advisory board, and then approved by the CDC director in order to become available. But this is expected by the end of next week. So, I saw another comment in the Q&A that there's been a lot of focus on the negatives of COVID. Are there any positives or glimmers of hope? And I think vaccination is such a huge glimmer of hope. And there are others that we're going to talk about related to the consequences of the pandemic. But this is really exciting. And then, of course, as I mentioned, vaccines have been available for children 12 to 18 years of age since May. So can you talk a little more about benefits of vaccination in terms of unvaccinated versus vaccinated kids? Are unvaccinated kids, do they get sicker if they catch COVID? Is that something that you see? Are they more able to infect other people? Is there a difference in how vaccines affect kids versus adults right now that we know of? Is it easier for unvaccinated kids, for instance, to catch COVID than unvaccinated adults? What are you seeing in terms of benefits of vaccination?
Sure. And I think what we medical experts agree is that vaccination is really what is going to get us out of this pandemic. And there's no doubt about the benefit of the vaccine, but it's hard to kind of visualize that benefit and understand that benefit for children specifically when you think about 50% of them are asymptomatic. So, you know, a parent that comes to me and says, but they got COVID, they're doing fine. Why on earth should I vaccinate them? It is sort of hard to understand that kind of global perspective. And what you talked about in terms of what benefit is it to them, what benefit is it to their family, what benefit is it to their grandparent who's living with them, or what benefit is it to them in the ability to go more freely to school or to go places that they may otherwise have not been. I think that's sort of what we need to focus on in terms of vaccination for children. In general, vaccines are part of what we do in pediatrics. We love vaccines. We do them day in and day out. And I mean that in a very kind of nice way, not that we love to poke these kids, but we really are passionate about protecting these children and making sure that we can protect them against a bunch of diseases. And so it really is the way of the world in pediatrics. You can't see a pediatrician's office without also then talking about vaccination. So like Dr. Dodd, it is something that I try to make sure that I have the conversation with every family coming through and try to understand, you know, what their perspective is. Why is it that they are for vaccines or against vaccines? And I will say there's probably two groups of people. There's one set who understandably are hesitant about vaccines, want to know more information, are asking about vaccines for themselves as well as their children. I see one of the questions in the chat box is, do you find parents who may have been reluctant to get vaccinated themselves are more willing to consider it after their children contract COVID? I don't know if it's the contracting COVID piece, because again, it probably went by as an asymptomatic infection. It was just a little bit of a cold. And I'm not sure that that drove them to getting vaccinated or getting them vaccinated. However, the opportunity to be able to protect their child sufficiently or to do something better for their child, that is important to a lot of parents. So if you are able to connect with them and tell them, hey, this is important for your child, this is why I think it's important, you know, why wouldn't you do it? And this is the same way I've approached the flu vaccine every year. You know, we know that the flu vaccine, COVID vaccine is 95% effective. We know that the flu vaccine some years is 40, 50% effective, some years 60, 70% effective. When parents have hesitancy about the flu vaccine, the way I think about it, gosh, why wouldn't I give my child 40, 50% rather than 0%? Like, why wouldn't I do that? And so, you know, why wouldn't I give them 95% protection rather than 0%? Is sort of how I look at it and I approach it with families. So I think families, there are two sets of families. One set who's understandably hesitant, willing to consider it. Another set who can't wait for it to be authorized in the 5 to 11 year age group. I have them, some of them texting me and asking every day in clinic, have you all got it? Are you going to be able to give it in your clinic? You know, do you have it? Which is exciting. So I think understanding what is the parent's hesitation, where is their hesitancy coming from, and being able to answer some of the questions that may be specific to that piece. I think that's sometimes the most important part of understanding how we're going to be able to do vaccines for children.
So let's talk for a moment about some specific scenarios. So are there any kids who should not be vaccinated with COVID-19 in those age groups where the vaccine's approved?
Do you mind if I start with this one? So the RNA vaccines are very safe vaccines. They have very few contraindications. very few allergy.
The Pfizer vaccine is right, is
Correct. My
type of
apologies.
vaccine called mRNA.
The mRNA vaccines, such as the Pfizer vaccine and also Moderna, but the Pfizer vaccine doesn't really have cross-reactivity with many allergens. I believe they use PEG, which is a stabilizing agent that's found in other medications and injections, but it's not something that's very commonly allergenic. So from an allergy perspective, there's really not much that would prevent a patient from being able to proceed with vaccination. The one risk that I think weighs on everybody's mind when considering the vaccine are the reports of myocarditis in patients. That's the swelling of the heart muscle. It's more common in young people, particularly males, more common in adolescents than, say, an 80-year-old. So that is always a consideration for these patients. I think if I had a patient who had a history of arrhythmia and was followed by cardiology, I would recommend that they discuss it with cardiology before getting the vaccine. But by and large, there are not many contraindications to vaccination.
Any other comments about contraindications, Dr. Jayshankar, or about side effects? Because you mentioned myocarditis, that's been observed, and certainly we see side effects in all vaccines. If you could talk about those, Dr. J.
Yes, so I think side effects seen with the COVID are similar to what we see with a lot of vaccinations, which is a little bit of fever, soreness at the vaccine site, sometimes swelling. There have been reports of some allergic reactions to vaccines, again, kind of the myocarditis subsect. This has been described in a very specific type of patient, more likely in female patients, more likely in sort of the young adult age group rather than in children. And so I think for a particular type of patient who may be a lady in her 30s, who may also have a history of lots of allergies, that may be the person that you would want to suggest speaking to their specialist, speaking to their specific doctors before just rushing into a vaccine. But I would agree with Dr. Dodd 100% in that, in general, there are very few side effects or problems associated with the vaccine, in that you can feel very comfortable and very safe in being able to administer these vaccines.
Well, and I know in medicine, we often have to think about a risk benefit. You know, what are the risks versus what are the benefits? Because with therapies, there's usually some kind of risk, maybe a very small risk. What can you tell us specifically about heart effects like myocarditis? Because that sounds kind of scary, I think, to a lot of parents when they hear that could be a side effect of a vaccine. What can you tell us about rates of that or seriousness of that with vaccination versus with COVID infection and disease?
Absolutely. So myocarditis, like I was saying before, is a swelling of the heart muscle itself. All cases of myocarditis, to my knowledge, in adolescents have been very self-limited. Some patients have required brief hospitalization for observation. Most are treated with NSAIDs like ibuprofen and self-resolve after a few days. Most occur within the first week after vaccination. Rates of myocarditis in the adolescent population appear to be about on the magnitude of 1 in 100,000. It could be 1 in 100,000 or 2 in 100,000, but it's somewhere in that range. Magnitude of myocarditis with COVID infection itself appears to be much higher, somewhere on the magnitude of 1 in 100, depending on which study. So it's almost 1,000 times more common to get myocarditis from COVID infection itself as it would be from getting vaccinated. And Dr. Edwards from Vanderbilt, who's a vaccine expert, recently gave a grand rounds to our pediatrics department and had this slide, which I think is awesome for discussing risks and benefits associated with vaccination. You can see even in males in the younger age group where myocarditis is the highest risk rate, compared with ICU admissions from COVID itself or hospitalizations from COVID, getting the vaccine is really a lower risk option. Delta variant specifically is very infectious. I think from a certain perspective, it's almost inevitable that exposure will occur at some point, unless something changes in terms of the pandemic itself. So really protecting yourself with the vaccine is both a data-driven option and as well as a very safe option.
Well, and I know that the new data that was shared last night in a national AAP webinar for the 5 to 11-year-old age group was similar, that the risk benefit suggested that the vaccines helped prevent disease very effectively. And in the participants that they had in the vaccine trials, they actually didn't see cases of myocarditis, probably because it's so rare, or other adverse events. So really promising data on the vaccine, and we'll hear more about that as it comes out in the next week publicly. But so I want to get to some of the questions that have been entered in the QA, but first a question for Dr. Palaha. So we've talked about safety and effectiveness of the vaccine, but it's still a shot, right? And it can be painful. Plus, some people just have anxiety about things like shots, right? Or even going to the doctor. So, how can parents and caregivers prepare their child to receive a vaccine? How can they make it easier for them?
It's a great question. I may not have a great answer. Taking your child along when you get the vaccine and modeling is a great idea, or an older sibling. We have some really cool little tricks we use for children who have to get a lot of injections, where we teach them to sing happy birthday and then blow the candles out. And that's when the injection goes in. And it's a really nice distraction, but also breathing technique that can reduce anxiety and just kind of keep the overall environment better. That tends to work well when you get a lot of repetition and practice, but not necessarily if you're already worked up about it before you head over to the doctor's office, and you're doing this once and not again for another year, right? So you're not trying to build a habit or a practice. So the bottom line is, again, they take their cue from the adult. The best thing you can do is soldier through it and be as matter of fact about it as possible. I'm not above, rewards for, these are not bribes. You're, it's kind of the payoff later for kids who do a good job of just kind of doing their civic duty and taking care of their own health and their family's health by getting their shot. I'm looking forward to some of these answers, by the way, so I'm going to stop there.
And I'd like to share something real quick in terms of that too, Dr. Palaha and Dr. Skatsina. One of the things I sometimes have the bigger kids do is play the piano, because that's what my daughter used to do at one time, was play the piano. So you can have the nurse hold the elbow steady or hold the arm steady, but then tell the kid to play the piano while they're getting their shot. And they're so focused on moving their fingers and playing the piano, as long as you and your nurse kind of know how to do it, they really don't even know that the shot's going into their arm. So I find that a nice way to do it for some of the older kids.
I love that, playing the piano. So certainly if any of our attendees have ideas for how you make things like shots, or how anyone could make things like shots easier for their kids, feel free to chat those in. And Katie, let's go ahead and see what kind of questions we have related to vaccines or any others we need to catch up on in the Q&A.
Okay, so we have from Rebecca Powers a question for Dr. Dodd. Have you had adolescent patients who want to be vaccinated, but the parents refuse to consent for them? And if so, how do you handle this situation?
Hi, Dr. Powers. So our clinic is not currently administering the vaccine, so I've not personally run across that that situation as a physician. So I have seen that sort of situation with the HPV vaccine in the past, and really on that front, I try and build a consensus with the family because I think consensus is so important. Tennessee state law does allow for minors to make decisions about their own medical treatment by the mature minor doctrine, which is it's somewhat of it's fairly vague as far as the criteria that go into that, but I think that could be an avenue that adolescents could pursue vaccination through. But really, I think the key is trying to bring the parents on board and building a consensus as a family.
So another question we have from Don Dale. What is the best scenario projection for the 5 to 11 vaccines in this area, and what degree of parental cooperation are you anticipating?
I am hoping November 2nd and 3rd are sort of banner days in my calendar. I'm hoping we're going to have full authorization for 5 to 11-year-olds, and I can celebrate with all the families that, yay, we have a vaccine for your age group, and can offer it to those families. I think parental cooperation, again, depends on their perception of the vaccine, their anxieties related to the vaccine, and the more that we can specifically ask, what is it you're worried about, and try to understand where they're coming from, and then have an answer to why it is they shouldn't be worried about that piece, the easier it is. I kind of do a little dance of joy every day in clinic when I'm able to give a flu vaccine to somebody that has had so far not considered it, or vaccinate a family that had otherwise been hesitant about any other type of vaccine. So my answer is, I hope we can get lots of people on board in that age group getting their vaccines.
Thank you so much, Dr. J. Next question kind of goes back to what we were talking about previously from Emily Curran. So there's a lot of focus on the negatives, the long-term effects, greater transmissibility with the Delta variant, high incident rate, et cetera. Going along with the idea of pandemic fatigue, are there any positives or even any glimmers of hope? And I do know we mentioned the vaccine for children. So one slide did show a significant and steady decline in incident. Are there any other things we can find positives or hope in?
I mean, I could speak to this one. In addition to the recent decline after the Delta surge, which is very heartening, we're finally seeing vaccine availability for our younger patients. Hopefully later this fall, the CDC will consider vaccination down to 6 months, which I think would go a long way for helping families feel more comfortable about the school situation and resolving some of those conflicts, help folks get back to hopefully a more normal state of life once we can kind of develop plans moving forward. I think that'll go a long way in terms of getting things back to normal.
All right, we have several questions regarding just the vaccine itself. One from an anonymous attendee. Curious as to why Pfizer has put out vaccines rather quickly for children versus Johnson & Johnson, who still doesn't have one.
Go ahead, Dr. Dodd.
Oh, I was just going to say, I've read some interesting things about Pfizer's vaccination program and just how structured they are and how ready they were at the start of the pandemic from an organizational standpoint to build these trials and be able to fund the trials, and they had the clinics lined up to be able to conduct the trials. They were just really prepared to be able to mount this sort of response.
I would agree. We are, obviously not in any research trial yet here in ETSU, but Dr. Edwards, when she spoke to us from Vanderbilt, kind of alluded to the same, that Pfizer was just very much more on the ball in submitting things. That's why they got the approval much sooner.
And then another question in regards to the vaccine is another attendee would like to know how researchers arrive at the cutoff age for a vaccine, as in what's considered weight, brain development, puberty, etc. Noting that some 4-year-olds will weigh more, maybe significantly more than a 5 or 6-year-old, whereas some teenagers can be the same size as an adult.
And I am not a researcher, so I don't know that I can 100% speak to this question. I do believe all of those factors are taken into account. I think I have a slide on the vaccine itself and how it's going to be available for children. Dr. Dodd, if you go to that slide, that kind of shows us that the vaccine is actually going to be not, like it's going to be a third of the adult dose, and how it is going to be, the volume. And I think all of those are certainly taken into consideration in development of the vaccine. But this is what is out there on the Tennessee Department of Health website also, in terms of how we can order the vaccines and what we expect it to be starting next week.
And
so I thought that was a really, really interesting and common question. And one thing I can tell you is that children's immune systems are still developing after they're born, particularly in infants and young children, but even in the first dozen years of life. And so I think that is a main piece of the rationale for these cutoff ages, because immune systems are just not fully developed. And so we expect that the response to vaccine may be really different based on age, and not as much with weight, but with age.
And I just wanted to make a comment on from a general medical standpoint. At least in adult medicine, a 30-year-old who's very muscular and maybe has a very high body weight, and a 90-year-old who's perhaps very slight, would have a similar medication starting dose or similar treatment for many ailments. And a lot of that comes down to just the way the medicines are studied, where they have to select a population and study and make sure it's safe within that population. And I think that approach itself probably lends some safety to patient variability, because those patients who are, the 90-year-old and the 30-year-old, if they're in the same study group and the medication works with low side effects for both those patients, hopefully you can make a more general statement about medication safety and efficacy, or safety and efficacy.
And I think, Dr. Skatsina, you bring up a great point. I would agree 100%. It really doesn't go by weight, as a lot of things do in pediatrics. For instance, it's the same dose. It's 0.5 ml of a tetanus vaccine, whether you do the tetanus vaccine as a little baby, a 1-year-old, a 5-year-old, a 7-year-old, as an adult, it's really the same dose. And so formulations are not very different based on weight.
Any other questions that you see that we need to get to Katie about vaccines? These have been great.
Yes,
So-
another.
I just wanted to comment on the myocarditis question about the length of myocarditis.
Sure. Go ahead, Dr. Duvall.
So I've seen several review articles out there about various case series with myocarditis and post-vaccine myocarditis in patients, and it looks like by and large, average length of hospitalization is probably about 1 to 2 days, and it usually self-resolves within several days.
All right, and another question we've had that's actually in the chat says, understand that the vaccine can help protect the community overall. Can you please explain how unvaccinated children can put vaccinated adults at risk of COVID-19? Should the vaccine in the adults prevent this?
I don't know who wants to take that
I could-
question. You want to?
Please go ahead, Dr.
Oh, sorry. I was just going to say, you know, if you look back at that slide about the community prevalence that was up earlier, showing for example, the Delta surge, that young adult, teenager age group was really driving that surge. I think it's reasonable to extrapolate and say that a lot of that was just because those kids are both unprotected by vaccination and also in high density settings like schools. And the fact that it's so prevalent in the community at that point really puts everybody at risk, including vaccinated adults. You know, as we know, vaccination is not perfect for preventing hospitalization. It's not perfect for preventing many of the complications of COVID in older adults. So the lower we can get our community rates, the better off we all are.
I see one more question, I believe, in the Q&A. Could a panel member explain the difference between mRNA vaccines and, say, the J&J?
I think Dr. Dodd had mentioned this. So Pfizer and the Moderna are like the mRNA vaccines. I would defer to Dr. Dodd in kind of explaining it further.
Sure. So, you know, traditionally the way that vaccines are made is they have proteins that generate an immune response that your body then learns to recognize a part of whatever you're trying to prevent. So for tetanus, your body learns to recognize the toxin the tetanus produces, and hopefully if you get infected with tetanus, your body can then fight it off because you already have those immune cells working to protect you. So the Johnson & Johnson vaccine was made kind of like that. They figured out a way to make a vaccine with those spike proteins that are in COVID, and then generate an immune response because your body is exposed directly to that protein, and then learns to recognize the protein when you're exposed to COVID itself. The way that the mRNA vaccines work is very similar to the way the virus works. So when a virus infects your body, it goes inside your cells, it hijacks your cellular machinery using something called mRNA, which is a blueprint for proteins. It makes your body make these virus proteins, and then the virus replicates itself in your cells and spreads throughout your body using that method. The mRNA vaccine has a very short blueprint for one of the proteins that's in the virus, the spike protein. And what happens when you get the mRNA vaccine, like Pfizer, is that the cells in your body, the immune cells in your muscle, make some of that protein. And instead of making a full virus that can cause the infection, they make that protein. They say, there's something going on with this protein. We need to see what the immune system thinks about it. They present it to the immune system, and then your immune system is able to recognize the protein and generate a response based off of that. So in a lot of ways, it's like you were infected with it's a very similar process to being infected by the virus, except there's no way that the mRNA vaccine could actually cause illness because it only makes that spike protein in limited quantities, and it generates a very effective immune response.
Thank you for that explanation, Dr. Dodd. I think we're going to shift gears now and
Hey, Karen.
pause on. Yes,
Can I ask a question about a follow-up
yeah.
question on that?
absolutely.
Thank you. I heard a community member on Monday night at the county commission meeting ask if, or state that it was her belief that when you get the vaccine and it creates that reaction that you were describing, Dr. Dodd, it actually puts live virus in your nostrils, and then you're more contagious than anybody walking around post-vaccine. True or false?
Not true.
That wasn't one of the
Agreed.
choices.
Not true.
Yeah,
Agreed,
Agreed.
not
False.
at all true.
False.
Agreed, false.
thank you. I just wanted to get that like little
Yeah.
detail out there.
You are not infectious after being vaccinated.
right.
Yeah.
In listening to your description, you covered all the bases in saying you won't get ill from the vaccine in the same way that you would from the virus. But I think it's really important to say you're also not contagious in the way that you would.
Yes,
Got
you may
it.
be very contagious without you knowing it because you may be asymptomatic, have just a little bit of a runny nose and a cold. You may
Sure.
be very contagious with a fever, but you are not contagious having gotten the vaccine
To others.
to others.
Correct. And I think you bring up a good point. There's lots of sort of misinformation out there and then just general confusion. And one thing we always think about, yeah, for certain, you cannot be contagious after getting a COVID-19 vaccine, but you have to think about now, again, heading into cold and flu season. And I already mentioned kids do get sick, with even fevers and illness. Normal, healthy kids, maybe half a dozen times in a year, that's expected. One thing that we see that's confusing to parents and caregivers during cold and flu season is you come in to get your vaccine and then the next day the child's sick. Well, what's going on there, again, because you can't get infected by the vaccine, is that they were already going to get one of those febrile illnesses. And it's just because that tends to happen more often during the cold and winter months. So I can see how that's really confusing. Were you going to say something else, Dr. Dodd?
I was going to say maybe part of where that concern comes from is some recent data questioning whether vaccination reduces viral load for breakthrough cases, and it may not reduce the ability to spread the virus for breakthrough cases, even if it does reduce the probability that you would get a breakthrough case, as well as the probability that you would get sick with the virus.
And I think, Dr. Skidzina, like you pointed out, I used to say that and continue to say it for the flu virus every year. I'll have families come and say, I will not take the flu vaccine. I took the shot last year, or I gave it to my child last year, and the week later they had the flu. So it caused the flu, I will not take it. And, I have to say over and over again, it is a kill virus vaccine. It cannot cause the flu. 100%, I can guarantee you're not going to get the flu from the shot. Now, did you meet the flu while you came to the office in my lobby to get the shot? And we know that that vaccine takes 3 or 4 weeks to start working. Is that unfortunately why you got the flu right after you came to the office? That I don't know. But, you know, I can guarantee, vouch for you, you're not going to get the flu from my flu shot. And so I think that's a really good point that you had brought up.
I just have to comment from the sort of behavior side of vaccine uptake. You know, we have really a bunch of different sort of working models around vaccine uptake in humans and behavior around accepting vaccines. The early childhood vaccine series are pretty high in terms of uptake because we've mandated them more or less for schools. But our flu vaccine uptake is terrible in general. Primary care clinics and adult populations see something like 30 to 50% uptake of the flu vaccine year to year. And I happen to know that in Washington County, where we offer the flu vaccine in schools for free, and all the parent has to do is sign a form, and your kid gets vaccinated at school, you don't have to pick them up and take them to the doctor, the uptake is around 10 to 13%. So I just think that's really helpful information for all of us in terms of setting expectations around what vaccine uptake is going to look like. Obviously, the pandemic is a whole different context, and we will see something different than what we've seen in other scenarios. But, you know, I think we all have hopes and dreams. We should have those, and we should all push the message, the hopeful message about vaccines. But also, I know there are other healthcare providers on the call and people who are, you know, want to stay optimistic about this, set expectations around what we know to be true in other vaccine scenarios, and just the wildly unpredictable nature of human behavior in some cases. And we just do the best we can with the messages we have for helping people make good choices.
So we have just a few more minutes, and I did want to touch on some other preventive measures in addition to vaccines. So as was mentioned in the Q&A, you know, masking and some of these other preventive interventions have been continued to be recommended or required in various locations and situations, particularly because we've seen so much transmission of the COVID-19 Delta variant. Some concerns that have been raised are particularly around masking in children. So Dr. Dixon asked a question. What is the evidence that wearing masks in schools cause harm to children?
I'll pick that up, and just you know, anyone else on the call that wants to jump in, feel free to do so. There's two stories here. The main one is that again, we don't have evidence from recent. Wearing masks in schools and around is a recent phenomenon. We don't have a lot of great studies, but we have a lot of great studies of prior similar kinds of disaster scenarios and stressful scenarios, and what exactly about them causes risk and causes harm. And we know that they are much more proximal and significant kinds of factors like economic loss and loss of resources, trauma around the loss or sickness of a loved one, and isolation or disruption of major routines. And those would be our best guesses from decades of studies of disaster on what would have a true impact and what has had. We have enough data now to know those are the real culprits in terms of kids' mental health. And masks are the way for us to avoid many of those things, or maybe all, right? And there really isn't a great explanation at hand for how mask wearing in and of itself could cause a mental health problem. Again, I know it sounds repetitive, but kids take their cues from adults. So adults who find it burdensome and difficult and challenging will certainly pass that kind of an attitude on. There is an argument made that smiles are important. And I've seen some literature on that, but it's a leap to take that to the mat in terms of a real immediate liability to children's mental health, particularly since we know that families and parents who can help buffer these kinds of their children from these kinds of stressors, masks being the least of concerns, sickness, loss, disruption being the more significant concerns, end up having positive outcomes. So strong role models, strong family bonds, good leadership in families are really what we need to get through the real risks, which are likely not the masks. We'll never probably have a study showing the impact of mask wearing, at least on large scale sort of mental health in general, because it's too confounded with too many other costs in this pandemic for anyone to really ever isolate masks by themselves. That's all I have to say about that.
And I think, Dr. Dodd, didn't you have some slides about sort of masking and?
Yeah, if you don't mind, if I could touch on that just briefly.
That would be great.
All right. There's a really big study from North Carolina. This was back in the springtime before the Delta surge hit, but over 800,000 students in 100 North Carolina school districts were studied. And what they did was they took districts and they made the recommendation that those districts just use masking as their intervention. So those kids were masked. They voted universal masking. They enforced masks within their schools. For the other school, for the experimental group, they did the masking, plus they had those students distance from each other. They spaced out cafeteria seating. They limited the number of students who could sit in a school bus. They really worked on spacing and other interventions to try, like air purifiers, things to reduce COVID transmission in addition to masking. And what they found was that not only were masks very effective in reducing spread during that period of time, they also found that those additional interventions didn't really add much to masking. So as far as interventions go, masking was very effective and eliminated the need for a lot of the spacing and these additional burdens to our educational environment. So I think it was a real, it really showed the positive benefit that masking can have in terms of controlling spread of the illness. And during the Delta surge, this is from the Michigan Department of Public Health. This data was released recently. You can see that schools that had less mask enforcement or less strict mask mandates really fared poorly during the Delta surge in terms of COVID rates, whereas schools that had mask mandates in effect did see increases in COVID rates, but not nearly to the extent of those districts that didn't enforce mask mandates. There are clearly some confounders with this sort of data. I'm sure that districts that encourage masking also may have higher vaccination rates in the community and maybe more, maybe we're a little bit more careful in terms of controlling exposure to symptomatic patients. But it's very encouraging in terms of the impact that masks can have in reducing the severity of an outbreak.
Thank you so much for that really helpful information on masks. We unfortunately are at the end of our time. So I am going to invite each of our panelists to share a sentence or two as a closing comment. And I want to relate this to Emily's question in the Q&A about getting back to normal. You know, what do you see that's hopeful, and what do you see as our timeline for getting back to normal? Of course, with kids, it's been wonderful to have more kids back in school this year, right? Because that's so important in terms of what's normal for kids. Dr. Palaha, you want to start with?
I'm supposed to be spreading messages of hope. Is that what my task is?
I think that's a wonderful way to close things out, don't you?
I think I need this therapeutically for myself, actually. So thank you for the exercise. I know at our house with our kids, we have really tried to turn the story about the pandemic into a story that will, underscore, their resilience in their life history. We talk about when their grandchildren ask about living through the pandemic, right? So, and that they had something happen in their childhood that, represented significant adversity that they overcame, and that they should feel proud of that. And I don't, for folks on the call who have teenagers or talk to adolescents, that seems to have been a narrative that really inspires and brings a sense of optimism to our house. So that's where I'll leave that.
Thanks, Dr. Palaha. Dr. Jaishankar.
I am excited by the hope of getting vaccines for the younger age group, in being able to really kind of focus our efforts on coming back to normal. I can't wait for next week. And I'm hoping that'll take us that huge step further in being able to get back to where we were.
Thank you, Dr. Jaishankar. And finally, Dr. Dodd.
My great hope is that with the decrease in the Delta surge and hopefully the uptick in vaccination, we'll see community rates fall to the point that it may be safer to resume some of these pre-pandemic activities, and hopefully our data and resources that we're putting into this pandemic will become fruitful and let us get back to normal.
All right. Well, thank you all for being here with us today. Thank you very much for our panelists and attendees. There was one question in the chat that we didn't get to, and I apologize for that, but it's given me an idea for another collaborative series session on this topic. So maybe we'll be able to convince some of our expert panel to come back again next year. So thank you all again, and stay safe and well. I hope you have a wonderful weekend.
Thank you, Karen Sketzina, you wonderful person. This was great.
Oh, stop, Jody Palaha Jones.
We can't thank you enough, Dr. Karen Sketzina. You're amazing. And thank you, Katie.
Duvall, who
Thank you, Katie,
with all the magic.
Oh, thanks.
Thank you all.
Thanks.